Hey everybody, welcome to the spring semester of the seminar series. I know it's unusual to have a seminar in the first week of the semester, but we made a special accommodations for our two famous speakers today. So thank you for accommodating their schedule. It's always a full room when Dr. Crawford's going to be speaking. But today we've got Stephanie Crawford and our new dean, Glen Schumock, going to be talking to us about some research that they completed just really recently. So this is hot off the press stuff. They were funded to produce a white paper, and they're going to talk to us about issues in medication safety in the community setting. Right?
Yep.
All right, it's all yours.
All right.
Good afternoon, everybody.
Can you hear Stephanie okay?
We're,
Speak up a little.
we're thrilled to have the people here in person, and we know at least one person called in. Just to start us off, you know, sometimes presentations are highly structured, and we make an analogy with classical music. You know how classical music has little cues like dolce when you want it sweet, or fortissimo when it should be booming and powered. Well, today, Dr. Dean Schumock
I'm
and
the
I,
sweet part.
Dean Schumock and I will have our own rhythm patterns. We'll make our own chords and structures. We'll take turns in who has the melody. So for today's presentation, rather than classical, which can be very good, today is more like jazz. All right.
Totally made up.
Dr. Schumock.
I'm not so convinced. Welcome, everybody. So yeah, Stephanie and I are happy to be here to talk about this project we did. We just finished really in December. Just give you a little bit of background on it. Are all of you familiar with the Chicago Tribune story that came out probably about a year ago on drug interactions? So they sent some investigative reporters into pharmacies across the Chicago area and basically had two prescriptions. It was fake prescriptions that were brought in basically by a fake patient, but the pharmacist didn't know that. And so the pharmacists then were asked to fill the prescriptions. They were prescriptions that have interactions, mostly very serious ones where, if you actually took these two drugs, there could be some potentially really adverse outcomes, including death. And so they basically recorded what happened then, whether or not the pharmacist filled the prescription, whether they counseled the patient about it, said anything at all about the drug interaction. The results were dismal, to say the least, in terms of pharmacies. I don't know. I don't remember the average percent of pharmacies that did anything about the drug interactions. It was less than 50%, as far as I can remember. It varied by type of pharmacy. So independent pharmacies and chain pharmacies, I think actually independent pharmacies may have done worse, which was a little bit surprising. And then across the chain, some did worse than others. I believe CVS did worse than Walgreens, but don't hold me to it. Am I going too slow? She's giving me signs down here. Middle finger, like, what? All right. Are you sure I can't just pontificate about this?
No, we got good stuff.
So anyway, after that, the college was thinking about putting together some sort of a white paper or a commentary on what what the profession should do, and there's a group of us involved. That kind of led to contact that Henry Manasseh had with this Moore Foundation. If you're not familiar with the Moore Foundation, it's a foundation in California. Gordon Moore was part of Intel and donated a bunch of money to this foundation. And they do all kinds of work, environmental research and science, and more recently healthcare. And very recently have gotten into medication safety. They're very interested in medication safety, and they've funded a number of different projects across the country. So anyway, they contacted Henry and have led to us getting funding to do a white paper. So let me just see if I can figure out how to work. Have you guys used Prezi before?
They say yes, we should go to them.
Okay, I got to use these arrows. Am I making you dizzy? All right. So we had some specific objectives for this white paper. it was specifically to focus on community pharmacy, and this is where the drug interaction thing was. But it's also kind of a general feeling from this foundation that that's maybe where the most opportunities exist. There's been a lot of work done, obviously, on medication safety in the hospital environment, much less so in community pharmacy. The specific aims were to examine the evidence that there are problems in the community setting, and this is across not just pharmacy, but across the healthcare kind of environment within the community. So from the physician's office to the pharmacy, even into the patient home. And then identify opportunities for improvement in medication safety. And that's where they want to focus on the pharmacist. What can the pharmacist do to be more involved in this? All right. So is this you or me?
Next, you.
Oh, okay. So this is what we're going to talk about. We're going to go over the methods of what we did for the white paper. This is a scoping review, and Stephanie will talk a little bit more about what that is if you don't know. So the scoping review included multiple pieces. There is literature. We actually looked at both gray literature and empiric literature, but then also looked at models of care, more review types of things. And then we also engaged some stakeholders, so we'll give you the results of those. And lastly, came up with some conclusions and recommendations. Now you?
Now me.
All right. We should have color-coded these.
We should let you know that while Dean, I got to get used to it, Dean Schumock and I had the privilege to presenting to you. This was truly a team effort. In addition, co-investigators were Tina Griffin, our liaison librarian, former Dean Bauman, Sandra Durley, and Henry Manasseh. Ladies and gentlemen, notice there were 3 deans involved in this. While I highlight them at the same time, you can imagine some people did a lot more of the work. Okay. As Dean Schumock said, we were funded by the Moore Foundation. So this is just the beginning. The full white paper was about 125, 130 pages, single-spaced, including references and appendices. So it's just a little tease today. Our methods, what we're going to talk about are the 3 circles on the right individually. We also note there was a review of the gray literature, which it says in the middle, because we wanted to see what the lay press was saying about medication use in the community, how safe it was, how it was not, but we're not going to go through that today. But students helped us a lot, including Anurag and others in that portion of the study. So the scoping review. How many of you are familiar with what a scoping review is? Oh boy, we got about 4 who are really cooking with oil here. How many have heard of a systematic review and are familiar with that? All right, that's most of the room. Scoping reviews are not quite systematic reviews, but there's a lot of overlap. As I state that, because I'm going to use this to say why we did a scoping review. These were our 2 research questions that we had to answer. What is the current evidence, meaning from the literature, on medication safety in the community setting? This was not limited to community pharmacy. This was any aspect, home use, office-based use, etc. What are the opportunities for pharmacists to improve medication use in the community? Again, not limited to community pharmacists or ambulatory care pharmacists, whatever pharmacists might be doing. As you look at those research questions, are they narrowly focused or are they kind of broad? Broad, exactly right, because if it's a systematic review, to synthesize the findings, it needs to be a very narrowly defined research question. These are broad. Broad questions can be handled in a scoping review because the purpose of a scoping review is to map the key concepts, what's going on, to look at the nature of evidence available, the depth and breadth of it, to see where the gaps exist. Thus, we conducted a scoping review. Our scoping review, unlike systematic reviews where you might state the systematic review only included randomized controlled trials, and it may have included observational studies. We could go deep, we could go broad, scoping, scanning, assessing. On top of that, though, it is systematic. We had to use many of the processes of a systematic review. We had to identify the research questions, identify the relevant studies, select the studies. They call it charting the data as we did our summaries of what was going on, collate it, summarize it, report it to you. And an optional step, an optional final stage in any scoping review is called expert consultation. We did that too. What did our scoping review look at? All these types of studies: experimental, quasi-experimental, observational, survey research, systematic reviews. What and when? One, we only included studies from developed countries. They had to be on the OECD list. We conducted our literature searches from June through October of last year. We only looked at the databases for Medline via PubMed and sent off full text for any studies published essentially the last 17 plus years. And we did notice some trends in how the emphases changed. Please stop me at any time. Again, because there is some structure in a scoping review, these were our inclusion and exclusion criteria. We had to count, and this was where working with Tina Griffin was very helpful. We had to include terms to identify a community setting. So ambulatory care, for example, was one of them. Now, what we also included terms you see as examples to identify safety. We had to exclude certain things. The sponsor was not interested at all in inpatient care. As Dean Schumock said, it's much more in the literature about hospital-based care and the medication safety. But we couldn't exclude community hospitals because, the word community, put it this way, we had to be very careful with the word community. Sometimes it was community hospitals. So we had to just kind of dance around, do a little tapping with this too, and coming up with the right search terms. We were not interested in illicit drug use, so you see falsified prescriptions and such were excluded. Not interested in diagnosis errors. We excluded long-term care and residential care if the medication management process was assisted. We were really trying to see when it's in the hands of the patients and or their caregivers. Any questions? This is the principal flow diagram. Can you see it well?
No.
How about now? All right. I'm going to go through this quickly. Essentially, when we looked through that time period of about 17 years, we had about 1,300 potential inclusion articles. Well, essentially, we removed the true duplicates, and that was quite a few. You see, records excluded were so many, we come back to me. We come down to 116. The ones who looked, with a big screen, we didn't look at the full articles. We only looked at titles and abstracts. And that was done by one of two study investigators, either myself or Tina Griffin. And that's how we came down to the 116. That's when Dr. Schumock and I got to start spending a lot of time communicating with each other because he and I both independently reviewed each of these. And you see the reasons why, but essentially of those 116, we took out another 33. If there were conflicts, and believe me, we had some conflicts, we discussed them jointly to resolve them. I gotta say a side note.
I didn't get a word in there.
Yeah, we started doing this big time in September, October. In October, we're also going to talk about the expert consultations. We had to do interviews together. We got to spend a lot of time, long hours with each other. He was a lucky man. So from 116, we removed the duplicates. This is what's in our study. Okay. We looked at 83 articles. You see, we had 4 completed RCTs, highest level of evidence in the absence of well-conducted meta-analyses of RCTs. We also included protocols if they were in the literature and, again, met our inclusion criteria. You see 3 quasi-experimental studies, a lot of observational studies, surveys, systematic reviews. Just show you a little bit more, to say a little bit more about some of these. Because I've stopped looking at my notes. I forgot I got to look down every now and then. With the randomized controlled trials, one of those was conducted here. Where he at? Dr. Touchette, wait, there you are. One of those was by Touchette et al., including Schumock. Essentially, the RC, well, I'll talk about those a little bit more. But those were the highest level of evidence, but see how few there are. Remember, we're looking at the nature and scope of these. I want to say just a little bit about the observational and survey research. They were very good, but very variable in the quality, very variable. So we might say just a little bit more about that later. Dr. Schumock, can you take just this one slide till I catch up in my notes?
I have no notes.
The other thing that we did was look at models of care. So there's a number of review papers out there where they've kind of looked at medication safety kind of from a systematic process. Some of you are familiar with the medication use process or drug use process, which was actually developed here, but looking at that process systematically and where problems occur in that, there's some nice models of care kind of papers that focus on medication safety like that. Anyway, so we tried to identify all of those kinds of articles and include those. A lot of them are developed by professional associations and so forth, but we want to make sure that if there had been previously conducted kind of large reviews like that focused on systems or models of care around medication safety, that we included those. You back?
Sort of. Back enough to talk. Don't go down yet. Oh, yeah, we can. Sorry. And the expert consultations. I treat him with so much more respect since he's become dean.
It was really bad before.
Sorry. What we did after our review of the empirical literature and the models of safety, we used that in order to identify target opportunities for greater pharmacist involvement, which we presented in a very short bullet list, 1.5 pages, to our potential expert panel. And we identified 18 very influential people. All of them agreed to participate. One was unable to later because of his schedule, but we were very happy and tight deadline asking them to look at all this, get it back to us very quickly. Of course, students, we never do anything with human subjects until we get institution review board approval. Multidisciplinary expert panel, you see the different areas they represented. Give you just a moment to digest that. We asked them to do 3 tasks. 1, remember we said we gave them the unranked list. Task 1 to our participants, and this is a little bit of results in addition to methods. We asked them to recommend 3 to 5 opportunities, either from that list or from their own thoughts, for pharmacists or others to improve medication use in the community. 16 of the 18 responded. From that, we took what they said as those opportunities, and Dean Schumock and I compiled an aggregated list. We had 39. We tried to make it as tight as possible. We had to do some combination. We tried to be true to what we heard them saying, but we had 39 different opportunities on that list. Second task they had was we gave them that list of 39 that we compiled from what they said in task 1, and we asked that they, I guess it should be a little higher, we asked that they rank the top 5, first choice, second choice, through 5th choice, their top 5 of opportunities for mainly pharmacists to improve medication safety and what needed to be done in terms of significance and practicality. Significance was the potential impact of safe medication use, unsafe medication use in the community. Practicality was the ability to implement. We said that your rankings on significance could differ from your rankings on practicality and might involve different opportunities. Task 3, we got those back. Then we determined essentially the top 5, it became top 5 or 6 with ties. Opportunities for pharmacists to improve medication safety in the community, and we had a one-on-one telephone interview with each participant, 17 of whom participated. Each interview lasted about up to 30 minutes. I would say most 25 to 30 minutes. We conducted 16 of those jointly, with one taking the lead in typing the notes. There was not audio recorded. One taking the lead in asking the questions, but also jotting notes as a background. We reviewed after each of those immediately what we had in our notes to make sure that we had down the major aspects. One needed to be performed by someone who was a night owl, because one participant was only available later in the day. But again, as soon as that interview was completed, I immediately reviewed the notes while the memory was right there to say, yeah, this is exactly what was stated. We conducted the interviews over 4 distinct days in early October. What we find? First of all, from the scoping review, it's going to be fun. But we excluded the 9 systematic reviews, which could have emanated from any country and involved a lot of different people on teams. So we're really looking at where did these studies emanate from if they were empirical review, excluding those 9 systematic reviews. A little over half were from the United States of America. 38% were from Europe. And hey, Dr. Touchette, 7% were from Canada. And 1%, which was one study, was from Australia. When we put it all together, and Dean Schumock and I had to say, what are we really seeing as the main things here? There were 8 major things that we came up with. The big one was the theme of integrating pharmacists in primary care teams. Now, this was interesting. All of this came only from those randomized controlled trials. That's all that looked at the integration of pharmacists in primary care teams. A big one was done in the United Kingdom, the UK. It's called the Pincer study, but it showed significantly reduced clinically meaningful medication errors from a major study using pharmacists, dedicated support information technologies, working with general practitioners at 72 different practices, 72. In the UK, with that, it was a total patient population of 470,000, of whom about 70,000 were included at risk. They were very well powered to show specific differences. Very specific research questions, and saying in this class of drugs, if you do this, does this occur? There was a study in a health maintenance organization. They were looking at alerts, the impact of alerts. Now, they used claims data, so they couldn't do causality, but with about 59,000 cases that were randomly divided from the beginning of what patients would get in the HMOs, they did show, at least for 2 medications, not for all. They said for the other ones, it just wasn't enough prescriptions. They showed the impact of those alerts. 2 other extraordinarily well-done studies, one by Touchette and others, the other by Farris and others. Karen, we know these teams did well. I don't remember the exact number of participants, but about 650 to 1,000. They came in each study extraordinarily close to the target sample size needed for the power. Were unable to, with enhanced pharmacist care, whether it be MTM or some other enhancement, they were unable to show a difference in the usual care groups versus the enhanced pharmacy groups in terms of lowered adverse drug events, but inappropriate drug prescribing was reduced. So one of the things we took from that is because ADEs can be described, adverse drug events, in so many different ways. If further studies just got to have a better definition, tighter definition to look for things very specific in what we want to look for. Another big thing, students, what's CPOE? I can't hear you. Very good. It's good enough. It's either computerized prescriber order entry or computerized physician order entry. Kind of same difference. A big thing was the use of CPOE or electronic prescribing. So, and this was the largest proportion of studies that we found in our scoping review. So, observational studies noted the need to improve the effectiveness of electronic health record prescribing systems with clinical decision support. But we did find out, and I'm highlighting more the problems, the gaps, and the good stuff. We did find, it was said that technology design issues contribute to electronic prescribing problems. Just think to yourself when you're trying to get something on the computer screen, such as auto-populated information functions, drop-down menus hitting the wrong thing, and the need for extensive mouse clicks. That didn't work. Updated systems are needed to prevent or reduce medication errors. Due to system interoperability and the lack of financial incentives to do so, pharmacists might not receive electronically discontinued or canceled prescriptions. Essentially, the physician might say, discontinue it, it's not transmitted to and or not received by the pharmacy that order. Thus, those discontinued prescriptions can be dispensed, causing problems in the community. There is missing information, and some of you are nodding who know this, missing information in electronically transmitted prescriptions that are problematic, because then the pharmacy staff have to add it in. Dr. Bursch, we're adding opportunities for medication errors the more you have to do the transcriptions to add it in. There are very mixed results in the literature regarding whether alerts to physicians or alerts to pharmacists contributed to or prevented errors and adverse events. Transitions of care. You might be thinking there's an awful lot of studies about medication reconciliation. There are. We only included them if it was very clear from the abstract that the emphasis was on improving patient safety, not only, whereas most of the emphasis optimizing medication care. So studies that looked at transitions of care definitely said medication reconciliation is needed, and across all transition points, which might or might not include community pharmacists. So much more research is needed in that. Vulnerable subpopulations. How do we define the elderly? Generally, who said? Oh, Dr. Lee, in his head, Lee. Said by their age. That's true. But Dr. Sephora gave a better one. Typically, it's defined as age 65 or older. Well, in our studies, that was what the elderly were defined, but faculty, some of you are going to love this. Some said 50 or older, and a few said, grad students are laughing, some said 60 plus, and a few were undefined. 11 studies or protocols did that. We know the reasons why vulnerable populations, which it was said we got to target those a bit more, need perhaps more attention, declining cognitive function, strategies to prevent adverse drug events, and to manage potentially inappropriate polypharmacy. There was also in the literature the need for more research and attention to pediatric populations, ambulatory pediatric populations, special need for communicating with low health literacy populations, and vulnerable groups who do not understand the dominant language of the culture. Remember, this was not just the United States. A lot of studies talked about the need to optimize communication in general, and some even said the need to build a network where people with safety problems can communicate with each other on solutions. We saw a lot about workplace environments. Working conditions, working environments contribute to unsafe medication use and practices. As several studies talked about the need to recommend examination of corporate, because remember we got independent pharmacy, community pharmacy, and a lot of other ambulatory care environments that might be through more change, to examine corporate or business policies or practices that are inconsistent with patient safety, including pharmacist workload. And there was also the need to look at shift handoffs, where you're changing shifts to see what's happening in the safety environment. Near the end, pharmacy technician roles, this was my longest one, pharmacy technician roles and qualifications. That was the knowledge base needed? We didn't, the studies did. Should they be certified or not? What level of training? Dr. Manassi was quoted in one study as saying, it's America's, quote, dirty little secret that we have untrained people in most cases behind the counter because the consumer might think everyone back there with a white coat on is really knowledgeable, but it's just as many people and probably even more voracious arguments, a hot button issue that says the uniform standards for training certification of pharmacy techs, and others would say there's no evidence. It's just a waste of money and unneeded. There were some additional practice considerations such as what happens in the home, need to look at drug interactions and others, but you get the idea. These were the major things. Dean Schumock.
So for the models of safety, a lot of the same things that Stephanie just talked about came through. Again, we kind of tried to look at these systematically in terms of the medication use process. We put together this big table with basically all of the issues that we got from these models of care from the different papers, and then we basically rank ordered those based on how often these things showed up in these different papers. There were, just to give you an idea of some of the papers that some of these you may recognize, there was a couple big reports that were done by AHRQ. So Kimberly Galt at Creighton was involved in one. She was one of our speakers at the seminar last year. And she's done a lot of work in medication safety, specifically in the community. Her paper really used the medication use process and tried to identify by going into physicians' offices where problems were occurring within that process. So that was very informative. ISMP, the Institute for Safe Medication Practices, had a couple of big review and papers where they looked at where these things are happening. HRQ had another paper by Webster that was models of care paper that was really useful, where they, again, kind of looked systematically across the medication use process and created these buckets of where problems are occurring, whether it's communication problems, judgment errors, delays in therapy, and so forth. Some of the other groups, AMA, the National Patient Safety Foundation. So there's a lot of groups that have investigated this in the past. So we wanted to make sure that we took advantage of what they found in those papers. This was basically the top items that we found from this part of our review. Medication history and reconciliation came up again and again as an opportunity for improvement in medication safety. Counseling and communication with patients was another top-ranked item, just that we could do that a lot better and that would improve medication use and safety. Next, kind of education of staff, making sure our staff understand quality, what it means to measure, monitor quality, ensure quality and safe practices. Transitions of care came up repeatedly, whether it's from the hospital to the community or vice versa, even some of the other sites of care. And then access to drug information, evidence-based medicine, more on the prescribing side. So we didn't restrict this, again, to things that were happening just within pharmacies. It also included physicians' offices. And so this one in particular focused on that. Safe and appropriate prescribing in the physician's office again. Medication monitoring and management, kind of across the spectrum of care. Use of technology came up again and again, whether it's physician order entry or within the pharmacy, safety alerts and use of computer systems and so forth. And then communication between healthcare professionals, whether or not pharmacists had access to prescribers, how they had access, whether that was in a timely fashion and so forth. And that kind of also got to the access to information, electronic medical records, and whether pharmacists could not only read but also write to those. And then last was kind of a culture of safety and making sure that corporately, especially in chain pharmacies, that safety was an issue that was taken seriously, and that there were decisions being made more from a financial standpoint than a safety standpoint. So what do we do next now? Okay, yeah.
Before you move on, I just wanted to talk a little bit about this last slide that you had.
Previous one?
Yeah, previous
Sure.
one. In all of these key themes, and I understand, this is a systematic review.
A scoping review.
Scoping review. And that, this, what gets published probably is provider-centric. But in many of these, we're not considering the role of the patient in patient safety. All of these approaches seem to sort of focus on some provider who's going to step in and fix things for the patient. And it's not consistent with a lot of the models of care that are emerging in chronic care. Just wanted to point that out. I mean, I think that there are ways to get patients more involved, more than just a pharmacist educating the patient.
Yeah.
But rather the patient, at least for those who have the cognitive ability to do that, to step in and be better equipped to manage their own safety as well.
We agree. Thank you so much, Dan. In fact, one thing we realized in retrospect was for our expert stakeholders, we did not include patient group advocacy, and we were saying that with the sponsor, so that might be one of the future research things that we should think about.
Well, and even patient groups may be looking to others to step in and fix things. I'm not sure that that would have changed what you found. But.
And this isn't, this is what we found in the literature.
Yeah.
So this is, we didn't exclude that. So, this basically shows you maybe the literature hasn't focused on that enough. Now, some of the models of care, there were some that we found, especially around nursing, that were more focused on the patient, and they weren't specific to medication safety, so we didn't end up including those in this. But yeah, totally get what you're saying. So Stephanie mentioned, though, that we took all of this literature and tried to boil it down, because what we wanted to do next was get the expert opinions on this. Take what we found in the literature, kind of put it in front of them, and then ask them, are these the things that you think are the most important barriers, opportunities, and issues around medication safety? So we came up with a list that had, I think it was around 40 items or so. We had them divided into categories based on the literature, and then sent that, as Stephanie said, out to the experts, and then asked them, go through this list, tell us what you think is important, but also if there's something missing from this that you think is that should be added, let us know what that is. So then we got that back, and we tried to consolidate all of their different suggestions, along with what we had in the original list, into something that was more manageable. That one was the one that had like 39 items on it. And then again, we sent that out and tried to get them to rank that. At this point, we hoped that we had all of their kind of ad hoc suggestions, and then we were just going to try to identify what were the priority items. It's kind of hard to show you those lists because they're so voluminous. So what we're showing here is really kind of what we came up with at the end. I think these lists are actually what we sent out kind of in the second task. This is a consolidated, and then these are the ones that were top ranked. So I'll just go through these. You can see there's some words that are crossed out. So as we did these interviews with the experts, we asked them what they thought of each of these items, and then based on the consensus that we were getting, we amended the items to try to capture more what the expert thought were the most important things. And you can see where these items came from in terms of whether they were considered more because they were significant to improving safety, or more because they were practical to implement. But so medication reconciliation across all points of care transition, that was the number one item, and these are in order. Establishing a culture of patient safety that's non-punitive, so more of the kind of corporate culture. A lot of these pharmacies, again, are chain pharmacies. Managing polypharmacy to prevent adverse events and drug interactions. So having the pharmacists act more on polypharmacy and drug interactions, which we talked about earlier. And then again, coming kind of back to corporate policies, inconsistency between policies in terms of what their focus is and whether or not they're aligned with patient safety. They might be more focused on how fast you can fill the prescriptions, how many prescriptions you can fill in a day, how much money you can make. And then, I don't know if I like this Prezio thing.
It doesn't like you too much either.
PowerPoint, you just kind of go through it.
We got about 7 minutes.
Okay, improving drug therapy management for vulnerable populations. You heard that already. Kind of the refill process. There's a lot of the experts identified the refill process as an opportunity to identify high-risk medications and intervene with patients. And then also patient communication, counseling, a lot of need for better communication with the patients. And then quality improvement programs and sharing data. You know, in the hospital, we can look at medication safety data and make improvements based on, you know, all of the different kind of quality metrics and things but in the community environment, this data is often kept confidential. It's, you know, it's hard to get access to it. And so it's hard to make improvements in safety. So, whoa.
There we go.
The interviews actually were great. They were a lot of fun talking to these people. They had a lot of great ideas. That was my favorite part of it, besides spending so much time with Stephanie.
I agree. And we apologize because we are going to have to kind of rush these last slides because we're going to lose some audience members. We want to point out this. We told you what was in the literature or a little bit of what the experts said, but now it's our recommendations. And Dan, please note, we actually have in here, there is still the need to accommodate patient preferences and consider individual contextual characteristics. So we didn't forget about it. We noticed, so thank you so much. Dr. Schumock, our dean, will quickly go over these three.
So basically, we tried to take everything that we heard from these experts, everything that we had looked at in the literature, and come up with some recommendations that we thought were coherent but also actionable by this organization and by our profession, really, because hopefully we can get this information out broadly. Then we bucketed them into three buckets. The first is kind of redesigning the patient care process within the community pharmacy. So a lot of comments about re-engineering the fill process, basically to free up pharmacists' time to provide more clinical services. So whether that's better use of technology or automation, synchronizing refills so that you're filling all of those prescriptions at once for a patient, that's more efficient, allows you to spend more time with the patient, optimizing use of technicians, Stephanie mentioned earlier, making sure that they're really used in a better way within the process to free up pharmacists' time, redesigning the workflow process to make sure it's as efficient and also as safe as possible, and then having better access to information so that that's also efficient and can improve safety. So basically redesigning what pharmacists do in the community pharmacy to make them, allow them to have more time to spend with patients. That's maybe the bottom line. And then the next one was organization level changes. So this is more maybe at the corporate level or the pharmacy level. Some of these might be harder to do. So those first ones, you could kind of see those happening. These, it's kind of up to the corporation, I guess. And we're mostly a chain pharmacy environment now. But so this safety culture, making sure policies align with safety rather than just profit. Public reporting of medication safety data so that we can all have access to it to help improve quality. Financial systems that incentivize kind of outcomes and safety. And that's beyond maybe the chain itself, but how we reimburse or pay for prescriptions. Right now we pay basically just to dispense the prescription. We don't pay for clinical care and safety and so forth as much. More pharmacist accountability, provider status, those kinds of things came up as being important to improve safety. A lot of legal and regulatory aspects were raised as barriers to pharmacy practice improvement in this environment. And so looking at those kinds of things to see if there's ways to make the legal environment, regulatory environment more flexible. And then getting back to the technicians, some uniform standards for technician training or certification to make sure that they can do the tasks that we want them to do and free up pharmacists. And then the last set of suggestions is around future research. So we suggested large-scale demonstration projects of the assessment of the impact of some of the specific pharmacy services that we talked about earlier. And then again, these research themes came from our expert panelists as well. I don't know if we mentioned that, but research on the impact of pharmacists on team-based care in the ambulatory environment, best practices around this engineered or new models of pharmacy practice in the community environment, but also ways to make that viable from a long-term standpoint. If there's a return on investment that we can demonstrate for pharmacies to do this, then they're more likely to do it. And we know that they're motivated by that. And so if we can incorporate that into ways to improve safety, we'd be better off. Assessments of the need for the credentialing of technicians, what the outcomes of that might be in terms of medication safety. More studies on technology. I mean, there's been a lot of these, but there still seems to be an issue there. And then also research on the role of patient safety organizations and others that are involved with kind of collecting or creating these databases of medication and safety data in the community environment. Do we have some final conclusions?
We do, which are a question. Does community pharmacy practice need a complete start over in order to improve medication safety? Let me give you another little analogy. This is a famous statue. Anyone know who this is a statue of? It's in who? Yes, outside of Jamestown, New York. This is supposed to be Lucille Ball. People called her Scary Lucy. Just had to make a new one so it would look more like it, but it was so many tourists coming to see Scary Lucy, they kept her up and just put the other one 75 yards away in a park. Dean Schumock, in 30 seconds or less, does community pharmacy need a complete redo to improve medication safety?
I don't, wait, was I supposed to say yes or no?
Oh, you're the...
I'm Scary Lucy?
You're Scary Lucy.
Yeah. Scary Lucy. Yeah, I mean, based on what we looked at and the need to re-engineer the entire process, I would say community pharmacy needs to redo it. Scary Lucy's too scary. She's even got a bottle like this.
If I might add, that's a bottle of Vitamita Benjamin. I say no, we don't need a complete redo. I absolutely agree with you. There needs to be more pharmacist accountability, responsibility for outcomes. We need provider status. I heard you say we need better access to medical information. I heard you say optimal use. We need best practices. We need research to find that. Not every place is like UIC. UIC is about the best it comes, but there are many good places, lots of pharmacists who are well equipped, just not doing it. So there's a paucity of evidence. We know it's not many randomized controlled trials or other high quality evidence. I did see some of the issues with observational studies and survey research, sampling issues, small sample sizes, but you get the picture. Our barriers can be overcome. There does need to be major reengineering. I just wouldn't say complete. And that's it, everyone. Thank you so much. We appreciate your attention.